This mini lecture is on movement disorders and tremors, allowing you to distinguish between the different types of tremors. Yes, you've got a good idea about it, but can sometimes be confused, I think, as most people can. The Parkinsonism and the different causes of Parkinsonism, and then the different movement disorders themselves. Myoclonus, which is spasming movements, athetosis, which is a slow rising movement, dystonia, which is a cramp-like contraction, dystonia, and chorea, which is sharp, dancey movements. We'll start with tremors. Intention tremor. The more you intend to do a movement, the more wild the movement becomes. So you might have seen people with bad cerebellar syndromes where the movement up until when they get close to your hand is smooth, and then it gets more and more wild. The further you reach, the harder it is to coordinate your movement. So don't you see people doing the finger-nose testing with the finger very close to the nose. You want to get the finger as far as you can from the nose, so they're rarely reaching in order to, so you can demonstrate that intention tremor. Everybody's got a little bit of intention tremor, and if ever you've been lazy enough to try and change the channel on the TV using a meter ruler or something like that, you've realized, or turn the light switch on, how difficult it is. That fine control is more difficult the further you get from and the more exposed it is, the longer the lever you have. So get the person rarely to reach to see that intention tremor. That's a sign of cerebellar disease. End of story. Next tremor is postural tremor. Postural tremor, you strike a posture, you strike a posture. And when you strike a posture, then you have the tremor. You're holding a cup, and there's a tremor. You're pointing, you're trying to do a precise operation. What settles this down? Alcohol settles postural tremors down very, very nicely, and lots of people who have postural tremors have an alcohol problem. Propranolol works very well as well. It's one of the few beta blockers that crosses the blood-brain barrier, so it turns off postural tremors quite nicely. It's the one that you saw black and white film surgeon have his drink before he goes in to do the operation to steady his hand. It's probably because he was an alcoholic and he was just withdrawing rather than had a tremor issue. So that's now intention tremors and postural tremors. Resting tremors, that's the tremor that you see when somebody's sitting down. Parkinsonism, end of story. When the person with a postural tremor strikes a pose, it's not usually quite so obvious as when he's sitting there. It's a coarse resting tremor. They sometimes have a bit of a fine postural tremor, but people with proper postural, inherited postural tremors, because it's autosomal dominant, can have titubation when they're sitting there, titubation, and quite a coarse postural tremor. So we've got resting, intention, postural. Do I have any others? No, that's all of them. Propranolol for a postural tremor. Parkinsonism causes a resting tremor. Intention tremor, cerebellar disease. Nice and clear? I will come back to Parkinsonism in a minute. These are a little acronym that I remember just to help me remember them for PACES purposes. The nice thing, again, when you had dysmetria being used for ataxia and dysdiadochokinesis, you can put all of these in dyskinesias. Dyskinesia covers all of these movement disorders. So if you've got somebody who's doing a funny movement and you don't really know what it is, term it a dyskinesia. Dys, kind of abnormal, kinesic movement. That's all it means. So I'll start off with myoclonus. Myoclonus, a sudden contraction of the muscle. For some strange reason, and it's got into all of our textbooks and even within the exam material itself, people put liver flaps, renal flaps, CO2 flaps in the myoclonic category as myoclonic. But if you think about it, what you do is you ask them to pull their muscle back, don't you? Hold their hands back. And all of the flaps are spontaneous relaxations of somebody trying to hold their hand back. That's not myoclonus, is it? It's periodic relaxation, not a spasmodic contraction. But for some strange reason, it seems to have polluted medical literature and also the exam. So liver flap, renal flap, and CO2 flap are all put in the myoclonic category. Actually, this is a really nasty sign of badness. Myoclonus is never a good sign. Myoclonus in ITU, somebody with hypoxic brain injury, as soon as you see myoclonus, you may as well just walk over to the machine and turn it off and everybody go home. Sign of really badness in the brain. If you've got a confusion, an old person who is confused, and you're putting it down to just a little bit of confusion secondary to a UTI, confusion secondary to a chest infection, and this is all a delirium. And you stand back and you can sometimes see these people doing little jerks, maybe jerks, as encephalitis. It's encephalitis that you're looking at, so it's a sign of encephalopathy. Myoclonus is a bad sign all around. Somebody having myoclonic epilepsy is most strongly associated with intercerebral tumor more than any type of seizure presentation. So myoclonus all round is bad news. Athetosis, dystonia. Athetosis is slow writhing movements. You frequently see this in, well, you might not see it so much anymore, people with Parkinson's disease who have been on L-DOPA therapy for a very long time end up with chorioathetosis, kind of a combination of slow writhing movements with very rapid movements. They are dysmetrias that are unpleasant for the patient. But which is better, being rigid or being fluid but constantly moving? So athetosis. These, as far as causes, have got very similar causes. Dystonia is a cramp-like contraction. It can happen for no reason that we can work out. Idiopathic. Secondary to medications. Cerebral palsy. Now, dystonia, I'm just going to expand on just very quickly. You've got your acute dystonias and your chronic dystonias, but I'd like to cover the most important dystonias, which are oculogyric crisis. People's eyes going everywhere, they can't focus, makes them feel very sick, not very nice at all. Oculogyric trismus and torticollis. Trismus is locked jaw, spasming of the jaw, a dystonia, acute dystonia. Suddenly the jaw locks, not very nice. Torticollis, spasming of one side of the neck, very uncomfortable. What I mean by acute is most of these are drug-induced. So when you take away lots of dopamine and anti-dopaminergic therapy, so these are antipsychotics, because schizophrenia is postulated to be excess amount of dopamine around. If you take away that, you take away the schizophrenia. But in the old antipsychotics that we used, these were not infrequent complications of them. Also, on top of that, we also use lots of anti-dopaminergic drugs when anybody walks into A&E and they're feeling a little bit sick. So you give them a drug that's anti-dopaminergic in order to stop them from vomiting, metoclopramide. And again, not infrequently, people get sent home with these. A week's course of it, the GP rewrites it up and carries on for weeks after weeks after weeks, and you can end up with these acute dystonias. Chronic dystonias, tardive dyskinesia. Tardive dyskinesia, that's that when they're constantly moving their mouth, sucking their lips. Sad thing about these chronic dystonias, tardive dyskinesia, it comes on late after somebody's been taking metoclopramide for the past year, is you can have a normal person stop the metoclopramide and then their tardive dyskinesia start on stopping their metoclopramide. So the change in that being on an antidopaminergic. It can happen just spontaneously after taking metoclopramide or antipsychotics for a year or 2 years. If you stop the therapy and wait a period of time, not everybody gets better. A third of people with tardive dyskinesia, that is a permanent problem, and it never goes away and is untreatable. These ones can be treated with antimuscarinics and procyclidine or benztropine. Either of those medications are the most commonly used. And you will see people who come in with an oculogyric crisis or trismus or torticollis, and the treatment is procyclidine or benztropine. As exam questions come up, yeah, quite common as exam questions. Somebody comes in, been on metoclopramide for this long, they have abnormal movements of their eyes that doesn't look quite like nystagmus, they feel very sick. What drug can you give them in order to settle things down? Procyclidine or benztropine. And chorea. Chorea, that actually means dance. This is most commonly associated with Huntington's chorea, Wilson's disease, Sydenham's chorea. Now, I've done a little review on the reverse side of the page. Of Wilson's and Huntington's disease. I can guarantee you that there will be a question in your exam about either Huntington's disease, Wilson's disease, and part of the complicating features is some of it are involved with metal. So what's the iron deposition abnormality? You get lots of deposition of iron in the pituitary, hemochromatosis. So in the back of your mind, you remember that you've got something to do with iron. You remember Wilson's has got something to do with copper, don't you? And Huntington's has got something to do with the brain and abnormal movement disorders. You do remember kind of psychosis and then dementia, abnormal movements. Those diseases will all coalesce into one disease in your brain as soon as you walk through the doors, unless you've had a good, thorough look at what it is that's going on. And these are the reasons why. Wilson's. It's a metal, and you get a combination of movement a psychosis, and something metally to do with the liver. So lots of copper deposition ends up with liver cirrhosis. Then you have hemochromatosis. Hemochromatosis, predominantly pituitary involvement, so it is gonadotrophic hypogonadism. Your testicles shrink because your pituitary, or anterior pituitary, has stopped producing LH and FSH. So you have pituitary involvement, so this has got something to do with the brain. And you also get iron deposition in the liver causing liver cirrhosis. And then you have Huntington's. And this one had something to do with psychosis and movement disorders. Huntington's and hemochromatosis, they've got H's in them, they're sounding very similar, and suddenly these, the psychosis and the movement disorders, this overlaps. These are very similar to here. The cirrhosis overlaps onto here, and the hema and Huntington's H part starts to confuse everything together. So I've done a little review on the back here. I've done hemochromatosis on another page. I should really put it on there. So Wilson's, we'll quickly have a quick chat about. Wilson's copper problem. Now, if you measure your serum copper levels and you measure your urinary copper levels, you have low serum copper levels and you have high urinary copper levels. The serum copper level is made up. When we measure serum copper, we measure ceruloplasmin, and we measure free copper and ceruloplasmin-bound copper. That gives us our serum copper level. So that's a normal person. Very small amounts of serum copper. Very large amounts of ceruloplasmin-bound copper. I'll show you somebody with Wilson's disease now. can you see that the amount of free serum copper is higher? And that's why you have a high urinary excretion of copper, because you can find it in your urine because it's free and it gets washed out. That free serum copper can also be deposited in tissues and cause damage because it hasn't been bound up to a protein or not. It hasn't been bound up to a protein. So overall, when we measure serum copper levels, we're not measuring serum-free copper levels, we're measuring the combination of those two. So it gets quite complicated when you're reading in a book which has increased, which has not. If you do a serum, send it to the lab, and you ask them to measure serum copper, they are going to measure the combination of the two. And in Wilson's disease, the combination of the two is lower. And that's the part that in your brain you can't quite get your head around, is why is serum copper levels low in somebody with Wilson's disease, yet they're having problems depositing everywhere? Because their free serum copper is higher, and that's being deposited. Does that make sense? We came across D-penicillamine earlier. D-penicillamine was preventing the cutaneous problems with systemic sclerosis. Steroids helping the lung problems, but D-penicillamine also helps bind up that free copper, take it away, and that's the treatment for Wilson's disease. Huntington's disease is a trinucleotide repeat disorder, so CAG, trinucleotide repeat disorder, CAG. And what happens is after you get about 100-odd repeats of this, the disease is silent until you get 100 repeats of this, and then you start getting expression of psychosis and personality change, and then frank dementia, and then the movement disorder comes up after the dementia starts to kick in. Very sad stories historically and all the way through Huntington's disease. Children of Huntington's, people who suffer from Huntington's, are given a choice of whether they would like to be tested for it or not. Frequently they say they don't want to be tested because they've seen their parent go through the horrible stages. Not infrequently, they haven't been tested, they still commit suicide because they can't face Huntington's disease. They have a post-mortem test and are found out not to have Huntington's disease. So it's quite a peculiar system because you do have to ask consent in order to be able to do a test. Yet people would still rather not know, but will still kill themselves, not knowing whether they've got it or not. Very peculiar, and I find it difficult to understand all around. But it may be something that you see if metabolic disease is something that you go into. There are lots of people with Huntington's disease around, much more than you think. So it's CAG on chromosome 4. The abnormality in producing the ceruloplasmin, this copper binding protein, the abnormality is ATP7B, and that's on chromosome 13. Sadly, it's just something that these are just things that you're going to need to remember. For some reason in my brain, I have chromosome 4 with an H in Huntington's. Again, there's no reason why. And something about the 13 with this being a W and this being an I for Wilson's. But if I taught that to you, you'd think I was insane. Okay. Parkinsonism. There are many causes of Parkinsonism. There is Parkinson's disease, idiopathic Parkinson's disease, which is the disease you've most commonly learned when you're back at medical school where people had a tremor. You gave them L-DOPA therapy, and there's plenty of other therapies now for Parkinson's disease. And their symptoms got better, and that was lovely. Idiopathic Parkinson's disease is only one cause of Parkinsonism. So Parkinsonism is a combination of a tremor, bradykinesia. Bradykinesia is a slowness of movement, and rigidity. Cogwheel rigidity is just a combination of increased tone, rigidity, and tremor at the same time, and what you're feeling is a tremor and rigidity. So it's not a separate feature, it's a combination of the three basic components of Parkinsonism. Idiopathic Parkinson's disease is only one cause of it. you may very commonly see drug-induced Parkinsonism. What drugs do you think may cause drug-induced Parkinsonism? Antipsychotics, antidopaminergics, the same drugs that could give you movement disorders. And either being on a drug for a long time or being on a drug for a long time and withdrawing it, either which way can actually precipitate a movement disorder. But idiopathic Parkinson's disease, drugs, and I would like to bring up Parkinson's Plus. Parkinson's Plus was a great invention for exams because it's taken away all of the other subclassifications of Parkinson's disease where you had striatal degeneration and what were the other old ones? You still see them in multiple choice questions and they shouldn't be there. Can you remember what the other ones were called? Olivo-Pontine degeneration, and there was another one as well, named after a person. What? No, not Lewy body, it was something else. But Parkinson Plus wraps up all of the remaining points, which is Parkinson's disease plus something else. So this is subdivided into two diseases, which is multi-systems atrophy and progressive supranuclear palsy. Multi-systems atrophy was the combinations of Parkinsonism plus either autonomic or cerebellar features. The only one of all of these that results to Parkinson's therapy, L-DOPA and all of the rest, is idiopathic Parkinson's disease. And there's some really nice characteristics about idiopathic Parkinson's disease that you find in that disease and none of the others. And that is that the features are asymmetrical. Tremor is worse on one side than it is on the other. The rigidity is worse on one side than on the other. If you find entirely symmetrical rigidity and the tremor is entirely symmetrical, it's unlikely to be idiopathic Parkinson's disease. It's more likely to be one of the others. The nice thing is that you can give a short trial of L-DOPA therapy to see whether the person responds. If they respond, then you've hammered the diagnosis. If they don't, then it's one of these. You can have a look for autonomic features and cerebellar features within the examination. Progressive supranuclear palsy, Dudley Moore, if anybody's heard of Dudley Moore died of progressive supranuclear palsy. He's the one that did the Arthur films before they were redone by the guy with funny hair. Progressive supranuclear palsy has an ocular abnormality where you retain your horizontal eye movements, but you lose your ability to be able to look up or down, so loss of vertical gaze. It's very rapidly progressing and tends to present with falls initially. People fall. A couple of years later, they end up with a couple of months later, they start to have problems with field deviation, so being able to look down the stairs, making their falls even worse. And then they get a pseudobulbar palsy. I'm going to talk about bulbar palsy and pseudobulbar palsy in a minute. So very poor prognosis with this one. The only one that responds to L-DOPA therapy is this one, and the only one that isn't symmetrical is this one. Bulbar palsy and pseudobulbar palsy, all this refers to is what you already understand about upper motor neuron nerve palsy and lower motor neuron nerve palsy. If you have an upper motor neuron nerve palsy, you end up with spasticity. If you have a lower motor neuron nerve palsy, you end up with flaccidity and fasciculation, so flaccid and fasciculating. All you do is supply this to all of the muscles that are involved with swallowing and speech and the tongue. And it allows you to distinguish between bulbar and pseudobulbar palsy. This is my brain. That's one hemisphere and the other hemisphere. I have my motor cortex over here. All of the fibers come down the internal capsule, travel down, and let's say they come to my brainstem to send signals to the motor nuclei of my cranial nerves. Now, these motor nuclei are kept within the brainstem itself. If I damage my brainstem here, so I have little strokes here, I can end up with a bulbar palsy. And a bulbar palsy is all of the muscles in the mouth and the swallowing having a lower motor neuron lesion. So a flaccid, fasciculating tongue and a flaccid palate. If I have a multi-infarct dementia up here, or a disease process affecting the brain here, I end up with an upper motor neuron nerve lesion of all of the same muscles to do with the tongue and the palate as well. And you end up with a stiff, spastic tongue and a stiff, spastic palate and a jaw jerk that's very exaggerated. And that is termed pseudobulbar palsy. So it's the same muscles that are affected. It's either increased tone, like an upper motor neuron, or a decreased tone, like a lower motor neuron lesion, and it's dependent on the anatomy of where it's caused. So it's a bit of a strange thought that you can have a stroke in your brainstem, which in your brain, and when you think about it, you think, that sounds, if it's in my brain, that should give me an upper motor neuron nerve lesion. No. The lower motor neuron nuclei of your brain of your cranial nerves is in your brainstem. So damaged strokes in your brainstem can cause lower motor neuron nerve lesions. Does that make sense? So we're going to go to the take-home points. Rigidity and tremor is asymmetrical in idiopathic Parkinson's disease, which characteristically responds well to L-DOPA therapy. Dystonia can be caused by both dopamine agonists used to treat Parkinson's disease and antagonists. So you can use dopamine antagonists, means all of the anti-dopamine therapies, antipsychotics, anti-sickness medications, they can cause movement disorders. But then so can L-DOPA, which increases the amount of dopamine that there is in the brain. That can give you a chorioathetosis, an athetosis. It's constantly moving. People with Parkinson's disease, you can see them with this abnormality. Chronic dystonia caused by dopamine antagonists, which are antipsychotics and antiemetics, are frequently permanent, even if medications are stopped. Those are tardive dyskinesias. When I say tardive dyskinesias, it's just the one thing, tardive dyskinesia. The other ones are acute, oculogyric, trismus lockjaw, and torticollis. In multi-systems atrophy, Parkinsonism is accompanied by cerebellar or autonomic features. So autonomic features, cardiac, that would be lack of heart rate variation. It would also blood pressure. You've seen people all of the time with autonomic instability just due to the fact that they're really old. And as soon as you get a young person and you suddenly realize that you see it all the time, 25-year-old comes in because they're a bit wet. You do obs with them every 4 hours and you see it, don't you? Straight across, blood pressure, systolic and diastolic, exactly the same. And it's just this band. You then go along to Mrs. Bloggs down at the end, who's 92 years old. And 1 minute her blood pressure is 68 on 42. And then they do their obs 2 hours later and it's 171 over 102, and then they come back later and they're getting called again to give her another set of fluids because her blood pressure's dropped to 68 on 30. That's just autonomic instability due to age. But you can also get that same autonomic instability due to multi-systems atrophy at a much earlier age. Diabetics, you see it all the time in diabetics as well. You know it, and when I say it to you, you realize it, but it's never actually sunk in when you're looking at it. You know the one when you pitch up at the patient, they're 25 years old, they had a blood pressure of 140 on, and they come back and their blood pressure is 68 on 20. Then you start to get scared, but Mrs. Bloggs, ignore it, just do the obs again and it'll be fine. Huntington's chorea is caused by a trinucleotide repeat disorder, a CAG trinucleotide repeat disorder on chromosome 4. Wilson's disease results in copper deposition and is associated with low ceruloplasmin levels and low serum copper levels. But actually, if you could subdivide it in the lab, you'd find that their serum-free copper was actually elevated. Actually, although idiopathic Parkinson's disease, L-DOPA works very well with idiopathic Parkinson's disease, it doesn't work with progressive supranuclear palsy, and actually makes people with multi-systems atrophy worse. So they come back and say they were even worse than they were before. Anybody done a Parkinson's clinic? Done a Parkinson's clinic? Generally, and the same holds true within the exam, they're quite nice and straightforward. The person comes back after 6 months on the same therapy that they're on before. You go through it. Can they still get out of bed? Can they still climb up the stairs? Can they still brush their teeth? No matter what they complain of, they still functionally do the same thing that they were doing before. You leave their drugs exactly the same way as they were before. It's only if now they can no longer dress themselves and they were able to dress themselves before that you change their medication. And that holds true within the exam. So they're quite nice and easy and straightforward to do. Did you find that? Did you find that that was the pattern? Okay. So let's go for the question. An elderly gentleman attends a general medical clinic following a number of falls that he attributes to his fast deteriorating mobility. His GP suspected idiopathic Parkinson's disease and started L-DOPA therapy, which seemed to have no effect on his symptoms. Whilst entering the clinic room, his gait is slow and shuffling, so it's trying to suggest a bradykinesia, which could be Parkinson's disease, but you can also get pseudo-Parkinson's disease. That's not a technical term, but it is a pseudo from multi-infarct dementia, and you see their shuffling gait. He reports repeatedly falling, particularly whilst walking downstairs, and has difficulty eating his breakfast. You perform a neurological examination on the patient. There is general slowness of movement, so that's bradykinesia, a subtle tremor, so we've now got a tremor, and both hands at rest. Examination of tone demonstrated symmetrical rigidity. So do you think he's got idiopathic Parkinson's disease? No, because you would expect asymmetrical signs. So this fits into either drug-induced, and it said nothing about drugs so far, multi-system atrophy, progressive supranuclear palsy, which are both under the title of Scheidegger, that's what I mean. Both under the title of multi-systems atrophy. So Scheidegger was an old name that was used that you still might see in questions, but it's all now Parkinson's plus, progressive supranuclear palsy, and multi-systems atrophy. Examination of his palate showed a spastic palate with a brisk jaw jerk. So Disha, what do you think it's saying there when you get a spastic palate with a brisk jaw jerk? Upper motor neuron, which is called a pseudobulbar palsy when it's to do with the mouth. Now, which of the causes of Parkinsonism that we've talked about gives you a pseudobulbar palsy? Guru? Progressive supranuclear palsy. So that's what the diagnosis is likely to be. Eating his breakfast. Why do you think he's having problems eating his breakfast? You can't see his breakfast. You can't look down and see it. He has to look straight forward. So either your face is in the breakfast. You did not examine his eyes, as he did not report any problems with visual acuity, and time is limited. His sensory symptom is essentially normal. Considering this patient's likely disease, which of the following statements is most accurate? The most likely diagnosis is multi-systems atrophy. They haven't talked about any autonomic neuropathy. They haven't talked about any cerebellar signs. So it's unlikely, it's less likely to be that than it would be PSP. The patient has a postural tremor, true or false? Yes, the biggest trap to fall into when it comes to tremors is postural and resting. Your brain wants to think, well, if you're sitting there, that's postural tremor because you're not really doing anything. Resting tremor and postural. Just keep on reminding yourself of the difference between those two. Resting tremor, Parkinsonism. Postural tremor, just benign essential tremor it's called, or postural tremor. Treatment with dopamine antagonists, not dopamine agonists, results in dystonia. Generally, you can get it with treatment with or without. You can either take the therapy away and it come on, and treatment with anything to do with dopamine. If you mess around with the dopamine system, you can end up with dystonias and other movement disorders. So the long and the short is messing with dopamine, whether it's increasing it or decreasing it, you can end up with movement disorders, dystonias, any one of the athetosis and chorea. Athetosis is the flow of small jerky movements. Slow writhing movements, athetosis. Chorea, dance, that's small jerky movements. It's unlikely that this patient has idiopathic Parkinson's disease. True. And often you'll find within the exam, there may be some parts of these answers that you really don't understand what it is that they're talking about. And you keep on going through, and you might not be able to sum up whether this is multi-systems atrophy or whether this is progressive supranuclear palsy. And all they're looking for is for you to be able to say that this is not Parkinson's disease. And it might be a simple stem when you get right to the end, to part 5. There's one thing that you can hang your hat on, but you don't even understand the rest of them. If his condition, so we've got the right answer, if his condition was caused by Wilson's disease, the defect would be on the ATP7B of chromosome 4. The ATP7B part is true, but it's on chromosome 13. Yeah, the 3 Wilsons. I'm just going to check if our tea's ready, whether we stop there or we try and squeeze a little bit more in. Normal pressure hydrocephalus, you can get, it is your triad of, but it's not Parkinson's. You do get, they can look a little bit Parkinsonian, but it's not a cause of Parkinsonism. Broad-based gait, dementia, urinary incontinence, those are your triad. Surprisingly prevalent out there, but it just isn't found early. It's found very, very late. Just a tandem gait, which is heel-toe walking, most sensitive test to pick up whether people have it. So when you see their gait, their normal gait might be, and their normal walking might be entirely normal, but tandem gait is most sensitive. And then they'll fall over and stagger. Any other questions? Okay, we'll stop and have some coffee.